Welcome to Topic 10, Neurological Disorders. In Part 1, we're going to go through a quick overview of the nervous system, and then we're going to spend a fair amount of time talking about motor and sensory pathways. Then we're going to talk about neuromuscular disorders, spinal cord injury, and finally we'll conclude with neurodegenerative disorders. Here's the learning objectives for the overview. The nervous system is divided into the central nervous system, which includes the neurons of the brain and spinal cord, and the peripheral nervous system, which include the cranial nerves and the spinal nerves. The peripheral nervous system serves as a link between the body and the central nervous system. There are two divisions of the peripheral nervous system, the sensory or afferent division. This takes in somatic and visceral sensory input from receptors to the central nervous system. The motor or efferent division is made up of motor nerve fibers that conduct impulses from the central nervous system to muscles and glands. This is further subdivided into the somatic nervous system, which is voluntary, which conducts impulses to skeletal muscles, and the autonomic nervous system, which is the visceral or involuntary branch that conducts impulses to cardiac muscle, smooth muscle, and glands. This is further subdivided into the sympathetic branch, which mobilizes the body systems for activity, and the parasympathetic branch, which conserves energy and promotes housekeeping activities at rest. You should review some of the major functional areas of the brain. This will be helpful, for instance, when trying to determine the outcome or manifestations for a stroke patient that, let's say, had damage to Broca's area. This list is certainly not comprehensive. There's a lot of other things that these parts of the brain do, but these are the things that I want you to focus on for this class. Okay, and this is just kind of a picture of the spinal cord showing the ventral horn, where we have motor neurons that leave, and the dorsal horn, which receives sensory neurons from the body. These come together to form like our spinal nerves. The central nervous system is protected by the skull and the vertebrae. We also have meninges, and these are membranes that line the structures and provide additional support and protection. Cerebral spinal fluid that helps to protect and cushion. And the blood-brain barrier that helps to separate circulating blood and cerebral spinal fluid in the central nervous system. So the peripheral nervous system contains all those neural structures outside of the brain and spinal cord, and it's going to provide a link to and from the external environment. So as I mentioned earlier, the axons are bundled into nerves. So the spinal nerves, we have 31 pairs. The cranial nerves, we have 12 pairs. The afferent pathways are going to convey info from sensory receptors to the central nervous system, and the efferent pathway is going to carry signals from the central nervous system to muscles and glands. In addition to the 31 spinal nerves, we also have 12 cranial nerves. Unlike the spinal nerves, which have both a motor and sensory component, some of the cranial nerves are sensory only, and I have a little mnemonic here, S, to signify that. For instance, olfactory is sensory only. Some are motor only. For instance, oculomotor is motor only. Some are both. For instance, trigeminal is both. And this is a way that you can help remember them. This other one's a way to help remember the order of the cranial nerves. You will actually not have to re-memorize all these again, although you may want to know the optic and the oculomotor nerves, and of course the vagus nerve. Okay, and the spinal nerves. So there's 31 pairs of these, and they are designated by the vertebral column that they exit. For instance, we have 8 cervical nerves, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. As I mentioned, all the spinal nerves contain both motor and sensory nerve fibers, both efferent and afferent nerve fibers. Okay, let's talk about reflexes. This is important when we're talking about spinal cord injuries. So reflexes are automatic, rapid, involuntary responses to a stimulus. For instance, a physician tapping on the patellar tendon of the quadriceps, that sensory information is conveyed to the spinal cord, and that which synapses with a motor neuron, which then produces contraction of the quadricep, and the knee kicks out. Now, this is a reflex that does not involve any higher brain centers. Now, yes, that information does get conveyed to higher brain centers, but that's after the knee has already kicked out. So what we're going to find when we talk about spinal cord injury, we can still have intact reflexes. They just can't be controlled from the central nervous system. Okay, so now we're going to talk about motor control and alterations in motor control. So let's look at the organization of motor control. So the motor cortex is the highest level of motor function. And this is where we have precise and intentional movements that can be initiated and controlled. We have different areas of the motor cortex. The primary motor cortex, this is the part which, if we stimulate it, we will see movement on the opposite side of the body. This has been mapped out, and this is shown here. We can see that like the face and the hands occupy a larger proportion of the motor cortex. The premotor and supplemotor regions of the brain are involved in processing and planning. The cerebellum is involved in timing and coordination of movements that are already in progress. It's also involved in maintenance of posture and equilibrium. It receives information from proprioceptors in the muscles and joints, input from visual and vestibular pathways. If this is damaged, this can lead to ataxia, which is loss of coordination and accuracy of limb movements. The basal nuclei is also involved in motor function, and they act to inhibit and modulate movement patterns from the primary motor cortex. So this helps to coordinate skeletal muscle activity. This is what gets affected in Parkinson's disease. The brainstem receives input from the cerebral cortex and subcortical nuclei, such as the basal nuclei. The medial descending pathways are involved in control of posture and integration of visual, vestibular, and somatosensory information. The lateral descending pathways are involved in controlling distal limb muscles. And then the spinal cord. From the spinal cord, we have the alpha or lower motor neurons that directly innervate the muscle. When we talk about a motor unit, we're referring to that alpha motor neuron and all the muscle fibers it stimulates. This is the motor neuron involved in reflexes. Okay, so it takes 2 neurons to get to a muscle. Okay, so it takes 2 neurons to get to a muscle. We have the upper motor neuron. Their cell bodies are located in the motor cortex, and most of these cross over at the level of the medulla and then travel down the opposite side of the spinal cord. Here then they synapse with the lower motor neuron to innervate the muscle. Let's talk about alterations in muscle strength. Paralysis or plegia means loss of movement. Paresis is weakness or incomplete loss of strength. Mono for one limb, hemi for both limbs on one side. Di or para, both upper or both lower limbs, and quadri or tetra, all 4 limbs. Muscle tone refers to the normal state of muscle tension. It can be assessed by palpating the muscle while at rest and during a passive stretching exercise. So the stretch, with the stretch reflex, let's say I'm passively moving somebody's muscle around the joint. The muscle stretches, that sensory information is carried to the spinal cord, and then motor neurons can cause the muscle to contract. Typically, if we have a lesion of the upper motor neuron, this is going to produce increased tone, whereas if it's to the lower motor neuron, the one that directly innervates the muscle, a lesion to that would produce decreased tone. Alterations in muscle tone. Hypotonia refers to a decrease in muscle tone. So here we have reduced resistance to passive movement around a joint. And this can be minor muscle weakness to flaccidity. And the causes of hypotonia include damage to the cerebellum, or damage to the lower motor neurons, or damage to the sensory neurons that would give that input to the lower motor neuron. So damage to neurons involved in that stretch reflex. A fasciculation is a twitching movement of muscle fibers, and this is caused by spontaneous contractions of all the muscle fibers in a motor unit. And this occurs with irritation or hyperexcitability of a motor neuron. This is also suggestive of lower motor neuron disease. Hypertonia is increased muscle tone. So here we have increased resistance to passive movement around a joint. In this case, upper motor neurons are damaged, but the lower motor neurons are still intact. Spasticity refers to a gradual increase in tone, causing increased resistance until the tone suddenly reduces. This is usually associated with damage to motor, premotor, and supplemental motor areas, or the lateral corticospinal tracts in the spinal cord. So damage to those upper motor neurons that synapse with that lower motor neuron directly to the muscle. Rigidity is when we have muscle resistance that is uniform throughout the range of motion. And this is due to just a kind of a tonic reflex activity. So here the muscles are firm and tense, and resistance to movement occurs in all directions. So this is associated with damage to the basal nuclei, which provide descending inhibition of the lower motor neurons. So the basal nuclei can normally kind of dampen that response, and if they're damaged, that can result in that rigidity. Hyperreflexia is when we have hyperactive reflexes, and this is due to upper motor neuron damage. Clonus is rhythmic contraction and relaxation of a limb in the stretch position, and that can occur with spastic paralysis. Hyporeflexia or areflexia, this is hypoactive or a lack of reflexes, and this would be associated with lower motor neuron damage. Okay, a few more. Ataxia is the wide gait associated with damage to the cerebellum. Dysmetria, so we have inaccuracies of movement due to cerebellar or vestibular damage. And then some other terms that are associated with damage to the basal nuclei. We have chorea. These are abnormal writhing movements. Dystonia. This is when we have contraction of an agonist muscle and an antagonist muscle at the same time. Tremor, be rhythmic movements of a body part. And bradykinesis refers to slowness of movement. Okay, so let's look at an upper versus a lower motor neuron lesion. So remember, we have those two neurons to get to the muscle. The upper motor neuron from the primary motor cortex that crosses over at the medulla, travels down the opposite or contralateral side, and then synapses with the lower motor neuron, which then goes to the muscle. So if we have an upper motor neuron lesion, this lesion could be either in the brain before crossing over at the level of the medulla, and this is going to result in a spastic paralysis of the contralateral muscles. And the reason why this is so is because the lower motor neuron reflexes are still intact. We still have the lower motor neuron and the sensory neuron, and so the reflexes are still intact, but this information is not controlled, or I should say the muscle is not controlled by the upper motor neuron system. So we've lost all communication with higher brain systems. Or we could have damage to the upper motor neuron lesion in the corticospinal tract. So this would be like due to a spinal cord injury. This is also going to result in spastic paralysis because we still have the reflexes, but it's going to be on the ipsilateral side because the upper motor neuron has already crossed over. Okay, and then finally we can also have lower motor neuron damage. Now this is damage to the neuron that actually innervates the muscle. So if this neuron is damaged, then we can't stimulate the muscle, and that's going to result in hypoactive reflexes, flaccid paralysis, and atrophy of the muscle. Okay, so let's compare and contrast upper motor neuron lesion with lower motor neuron lesion. Paralysis would be spastic if it's upper, flaccid if it's lower. Muscle tone, hypertonia with upper, hypotonia with lower. Muscle bulk, we would get disuse atrophy because the muscle's not being stimulated, or the lower motor neuron's not being stimulated from the upper motor neuron. And with a lower motor neuron lesion, we would get atrophy and fasciculations. Deep tendon reflexes, we'd have a hyperreflexia response with the upper motor neuron lesion, and a hyporeflexia with a lower motor neuron lesion. And we can also have pathological reflexes, such as the Babinski reflex with the upper motor neuron lesion, which we would not see with the lower motor neuron lesion. The other thing to remember is depending on where the upper motor neuron is damaged. So if the upper motor neuron lesion is above the medulla, it will be contralateral, and if it's after the medulla, it will be ipsilateral. If the lower motor neuron is damaged, the clinical findings will be ipsilateral. Okay, so answer for yourself, what would the term we would use to describe a defect causing weakness in both arms, a weakness in the right arm and leg, and inability to move one leg? Okay, next we're going to talk about disorders of the motor unit and peripheral nervous system disorders. So diseases of the motor unit, most of these lead to wasting of the skeletal muscle. These include lower motor neuron lesions or disorders, disorders that affect the nerve axon. These are called peripheral neuropathies. Disorders that affect the neuromuscular junction, such as drug and toxin-induced disorders and myasthenia gravis, and then disorders that affect the muscle fibers, and these are called myopathies. Muscular dystrophy is a type of myopathy. It is a genetic disorder that leads to degeneration of both skeletal and cardiac muscle. It's caused by mutations in the dystrophin gene, which codes for dystrophin, a protein that maintains structural integrity of both skeletal and cardiac muscle. The most common of the muscular dystrophies is Duchenne muscular dystrophy, and this is an X-linked recessive trait. So girls will not get it, but boys have a 1 in 4 chance of getting it if they have a carrier mother and an unaffected father. It is the most common and severe type of muscular dystrophy. If we look at the clinical course of Duchenne muscular dystrophy, it's asymptomatic in birth and infancy, and they have normal early growth movements. But around 2 to 3 years of age, they start having muscle weakness and clumsiness with frequent falling. They have progressive difficulty walking and using, and they end up using a wheelchair, usually by age 7 to 12 years of age. The postural muscles of the hip and the shoulders usually tend to be affected first, while the distal muscles that control urination and defecation are well preserved. They can develop the pseudohypertrophy and large calf muscles, which the muscle is eventually replaced by fat and connective tissue. It's not stronger, it's not more muscle. but rather that's why it's called pseudohypertrophy. Muscle contractures and deformities, including scoliosis, are common. And eventually, the patients their diaphragm becomes so weak that their respiratory movements are ineffective, their cough is ineffective, and this can make them predisposed to pneumonia and aspiration of food and fluid. They can also have cardiomyopathy of varying severities, and death usually results from either a severe respiratory infection or problems with cardiac muscle. Okay, let's take a look at dysfunction of the neuromuscular junction. Okay, so I just have two examples for you here. QRA is a drug, a toxin, that can bind to acetylcholine receptors at the neuromuscular junction, but they don't produce a depolarizing response. So if we remember the neuromuscular junction, the motor neuron releases acetylcholine into the synaptic cleft. It diffuses across the synaptic cleft and then binds to acetylcholine receptors at the neuromuscular junction, which produces a depolarizing response, which then causes opening of voltage-gated sodium channels and an action potential in that muscle. So curare essentially blocks those acetylcholine receptors and prevents acetylcholine from binding and producing a response. Botulism, on the other hand, inhibits the release of acetylcholine from the motor neuron, so there's not enough acetylcholine to bind to the muscle and produce a response. This has been capitalized on through the use of Botox to inhibit muscles in the face to prevent formation of wrinkles. Myasthenia gravis. This is an autoimmune disorder at the neuromuscular junction. Here we have autoantibodies to acetylcholine receptors that bind and damage, or I guess produce an inflammatory response, I should say, and that leads to destruction of the acetylcholine receptors, and that's going to lead to weakness in the skeletal muscle, because there's not going to be enough to produce a strong enough response. This is an autoimmune disorder that has been linked to thymus gland abnormalities. Signs and symptoms include muscle weakness that usually begins in the face and eyes. This fatigue worsens with activity and improves with rest. They have double vision sometimes. Drooping eyes is very common. Monotone speech, difficulty chewing and swallowing, droopy head, arms become weaker. Upper respiratory infections if the diaphragm is affected. Treatment is aimed at giving acetylcholine esterase agents. So these are agents that are going to inhibit the enzyme that breaks down acetylcholine so that acetylcholine can last longer at the neuromuscular junctions. Oh, sorry, yes, it is cholinesterase agents. I had that correct. Less breakdown of acetylcholine, so more depolarization. Glucocorticoids for the inflammatory response. Plasmapheresis, if they're having an acute crisis, you can wash out the antibodies in their blood. And then removal of the thymus gland. Okay, let's look at some peripheral nerve disorders. And these are disorders of the motor and sensory neurons outside of the central nervous system. And these are going to result in muscle weakness and sensory changes. There's two main types of injury: segmental demyelination, and this involves the Schwann cells. And there's some hereditary motor and sensory neuropathies, or this can also occur with damage to the myelin sheath. We also have axonal degeneration, and this is if we have a primary injury to the neuronal cell body or its action. axon. And this can be due to an injury, or it could be due to degenerative changes called neuropathies. Now, damaged axons within the peripheral nervous system may regenerate in time, but remember, central nervous system axons may not. One mononeuropathy is carpal tunnel syndrome, and this is caused by compression of the medial nerve by the transverse carpal ligament. This can be the result of a systemic disease, but it's usually a result of repetitive flexion and extension movements. This is treated with NSAIDs, corticosteroid injections, splints, rehabilitation, X-rays, and potentially surgery to release that compression. Polyneuropathies involve multiple nerves, and here we can have demyelination or axonal degeneration. And this can result in symmetric sensory, motor, or mixed sensory and motor deficits. It may involve autonomic nerves, which can result in things like hypotension and impotence. It can be caused by toxic agents such as lead, or alcoholic, arsenic, metabolic, diabetes mellitus, uremia with kidney failure, immune-mediated, such as the Guillain-Barré syndrome. Guillain-Barré syndrome is an acute, life-threatening, immune-mediated polyneuropathy. And this usually occurs following some acute event such as influenza illness. It results in rapid and progressive limb weakness and loss of tendon reflexes, and that can lead to asymmetric flaccid paralysis, which can affect the respiratory muscles, which then can be life-threatening. If we have autonomic nervous system involvement, that can also cause hypotension, arrhythmias, flushing, sweating, and urinary retention. Treatment is with high doses of IV immunoglobulin therapy. Most patients have a full recovery in about 6 to 12 months. Okay, so take a look at the concept check and make sure you're following along. And now we're going to move on to spinal cord injuries. Okay, once again, let's review those motor pathways. So we have the upper motor neuron from the primary motor cortex that then crosses over at the medulla and then synapses in the spinal cord with a lower motor neuron that goes to the muscles. Sensory pathways, so this provides afferent information from the body to the central nervous system. We actually have rather than 2 neurons in a chain, here we have 3. And we have 2 main pathways. The dorsal column is involved in the sensations of fine touch, vibration, kinesthesia, and pressure senses. These come in to the spinal cord, and then they travel up the dorsal columns ipsilaterally, and then they synapse with a second order neuron in the medulla, which crosses over and travels up the or stays on the opposite side of the brain, and then synapses with a third order neuron in the thalamus, which then synapses in the sensory cortex found in the parietal lobe. The spinal thalamic pathway involves the senses of pain and temperature. These travel a little bit differently. So pain and temperature sensations come in from one side of the body into the spinal cord, where they synapse with the second order neuron right away, and the second order neuron crosses over at the level of the spinal cord and then travels up the opposite side to the thalamus, and then the third order thalamus synapses with a second order neuron, and then that travels to the sensory cortex in the parietal lobe. Okay, so note the different places that these cross over. Okay, they both eventually cross over and synapse on the opposite side of the brain. So sensations on the right side of the body ultimately are going to be perceived on the left side of the brain. But those that travel up the dorsal column are going to travel up the same side of the spinal cord and don't cross over till the medulla, whereas pain and temperature crosses over at the level of the spinal cord that it comes in and then travels up on the contralateral side. Okay, so spinal cord injury can result from a fracture, a dislocation, or compression of the vertebrae. And this can compress the neurons, stretch, or tear the spinal cord neurons. This can be a result of hyperextension or hyperflexion with possible fracture. This can result in a complete or partial spinal cord injury. There are many different types of partial spinal cord injuries. We're only going to talk about one. That's the Brown-Séquard syndrome. And this is where we have damage to the cord just on one side of the body. So in this case, we lose motor function on the side of the damage, and we also lose touch, vibration, kinesthesia, and pressure on the side of the damage, but we have a loss of pain and temperature sensation on the opposite side. Okay, spinal shock. Spinal shock is the period immediately following injury when normal activity of the spinal cord ceases at and below the level of injury. So we're kind of in a state of shock. Okay, so during the period of spinal shock, we lose all reflexes, all autonomic, reflex, motor, and sensory activity is lost in the segments at and below and slightly above due to inflammation, the injury or lesion. So this is going to result in no motor or sensory impulses, resulting in flaccid paralysis and no sensation. During this time, we also have the absence of all reflexes, including autonomic reflexes. So we get urinary retention, paralytic ileus, and a low blood pressure. So this is the period of spinal shock immediately after the injury. Now, eventually spinal shock will go away. Recovery from spinal shock is going to be indicated when we have the gradual return of reflex activity. So once reflex start returning, for instance with skeletal muscles, flaccid paralysis will become spastic. This occurs because as inflammation gradually subsides, and this period of time can last from hours to weeks after the initial spinal cord injury. So let's talk about permanent effects. So after spinal cord shock is over, then we can assess the permanent effects of the spinal cord injury. And this is of course going to depend on the level of injury. Obviously the higher up in the spinal cord, the more body segments that are going to be affected. It's also going to depend on the area of the cord that was damaged. Did it only damage the left side, or did it damage the whole? Did it damage the anterior side or the dorsal side, and so forth? So that could result in a partial spinal cord injury. And also the extent of the damage, how severe is it? Reflexes will return when spinal shock resolves, but remember those reflexes aren't going to be able to be controlled by the central nervous system, okay? Because we've lost communication by severing the spinal cord, damaging the spinal cord. We've lost communication between the central nervous system and the peripheral nervous system. So this is going to result in spastic paralysis. Initially, during spinal shock, we had kind of a flaccid bladder. Now we're going to have bladder and bowel incontinence. So it can still fill and contract, but it can't be controlled. In terms of the level of injury, obviously cervical injuries are going to be affect more parts of the body than lumbar injuries. Cervical injuries, we lose motor and sensory function in the arms, in the trunk, and the legs. This also affects respiratory function, the sympathetic nervous system function, because the sympathetic nervous system comes out of the thoracic lumbar sections, and all sacral parasympathetic fibers are also affected. Lumbar injuries, so way down here, are going to interfere with function of just the lower extremities and the sacral parasympathetic nerves. Okay, this slide looks at the level of injury, of spinal cord injury, and what sensory motor function will remain, or what you'll lose. Refers to how dependent are you going to be for dressing and eating, for elimination, and for mobility. You certainly don't need to memorize this chart, but you should understand some things. That a cervical injury obviously is going to be much more severe, and that will affect ventilation. Okay, so let's look at some of these permanent effects of spinal cord injury. Reflex activities. If we have an upper motor neuron injury at T12 and above, we have spinal cord reflexes that are intact, except for at the absolute level of injury. Okay, but if the lower motor neuron is damaged, so wherever the lower motor neuron is damaged, then we won't have reflexes. But all of the damage to the upper motor neurons are going to allow the spinal cord reflexes to be intact, but that pathway to the higher center is lost. So this is going to result in spasticity of skeletal muscle and smooth and skeletal muscles that control the bowel, bladder, and sexual function. If we're talking about below T12, then we're just affecting lower motor neurons. And this is going to cause reflexes to be damaged at the level of the spinal cord, resulting in a decrease or absence of reflex function. So here we're going to get flaccid paralysis of skeletal muscle and smooth and skeletal muscles that control bowel, bladder, and sexual function. If we look at respiratory muscle functions, patients with injuries to C1 to C3 are going to require assisted ventilation. So if you remember, the diaphragm is innervated by segments coming out of C3 to C5. They also have innervation of the intercostal muscles, which assist in respiration from T1 to T7, and abdominal muscles, which can assist with the forced expiration, come out between T6 and T12. So patients with injuries to C3 to C5, ventilation is diminished, and they're going to present with shallow breaths and a weak, ineffectual cough. Let's look at disruption of autonomic nervous system function. So sympathetic nervous system, the outflow from thoracic and lumbar regions is affected if it's above or within that region. Parasympathetic, outflow from the sacral cord is affected, but outflow from the vagus nerve is not affected because that actually comes from the brainstem. It's one of the cranial nerves rather than being a spinal nerve. Autonomic reflexes below the level of injury are going to be uncontrolled, while those above are controlled. Some responses we can get a vasovagal response where we have dysfunction of the sympathetic result that results in increased vagus nerve output, and that can cause severe bradycardia and hypotension. And then another condition we can have is autonomic dysreflexia, and this is an acute serious complication that's caused by a sensory stimulus that triggers a sympathetic reflex response, but that can't be controlled from the brain. So let's take a look at that next. Okay, so this can occur in patients with a spinal cord injury at T6 or above because they lose the central nervous system control of sympathetic reflexes below the level of injury. Okay, so we have some visceral stimulus such as an over-distended bladder, an over-distended rectum, a bed sore, you name it. Okay, And this sensory stimulus goes in, but it's blocked. It can't travel to the brain, but it can cause activation of the sympathetic chain ganglia that are found near the spinal cord. So this can lead to uncontrolled activation of local sympathetic reflexes below the level of injury. One of the things we get is piloerection. It causes vasoconstriction of blood vessels below the level of injury. So this is going to result in pale, cool, moist skin. This massive vasoconstriction is going to result in an acute rise in blood pressure. That blood pressure is going to be sensed by baroreceptors, which will activate the output of the vagus nerve, which will cause slowing of the heart. It will also, above the level of injury, we will have decreased sympathetic outflow, causing vasodilation and sweating above the level of injury. And this can cause headache and flushed skin. This is a life-threatening emergency because it can cause stroke or heart failure due to the extremely high blood pressure. So note this patient here. So very red and flushed above the level of injury, pale below the level of injury. It's important in these patients to reduce the blood pressure, although it's important to do it in a controlled manner and not suddenly send them into shock. Okay, you should take a look at these concept check questions and make sure that you can answer them. Okay, finally, we're going to talk about chronic neurodegenerative disorders. So these are disorders that progress chronically over time. For each of these, you're going to want to be able to describe where is the lesion, what part of the nervous system is the lesion occur, what is the etiology or cause, is there a typical age of onset, does it tend to affect males or females more, what is the pathophysiology, and how does that relate to the clinical manifestations of each of these disorders. Okay, the three main characteristics of Parkinson's disease are tremor, rigidity, and bradykinesia. Tremors occur at rest and they affect the hands, the feet, the face, the tongue, and the lips. You can get a pill rolling motion of the hands, increased muscle rigidity, and decreased flexibility. We see flexion, contractions in the knees, in the hips, in the elbows, in the wrists, a stooped posture, a stiff or mask-like facial expression, a low voice that's devoid of inflection. Chewing and swallowing become difficult, and this can result in drooling. Bradykinesia, this is difficulty initiating and stopping movements, resulting in a propulsive gait, and they have difficulty with complex activities. They're very slow. And then autonomic dysfunction, sweating, salivation, constipation, urinary incontinence, and impotence. In about 20 to 30% of patients, dementia occurs late in the course of the disease. Primary Parkinson's disease develops usually after the age of 50. This is an unknown cause, but a genetic environment link is suspected. Inherited forms of early onset Parkinson's disease also can occur, such as in the case of Michael J. Fox. Secondary Parkinson's is due to some secondary or some primary problems, such as encephalitis, stroke, trauma, sports injuries, or may be induced by drugs that block dopamine receptors. Treatment. There is no cure, but it can be treated with drugs to increase dopamine levels or stimulate the dopamine receptors, or to inhibit dopamine breakdown. Deep brain stimulation has also been used. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease after the famous baseball player who had this disorder. The pathogenesis is unknown. However, a couple of things we do know. We have about 5 to 10% are familial, and there is autosomal dominant inheritance. These patients tend to have, or all patients with ALS tend to have high levels of glutamate. This usually occurs in middle to late adulthood and involves men more than women. It results in a progressive degeneration of both upper motor neurons in the cerebral cortex and lower motor neurons in the brainstem and spinal cord, and this proceeds without inflammation. Amylotropic refers to muscle wasting, and sclerosis refers to hardening, and lateral, of course, to the lateral corticospinal tracts. With ALS, it's important to remember that intellectual and sensory functions are not affected. It is a motor disorder only. Symptoms usually begin with muscle weakness and atrophy in distal muscles of one upper extremity, like in the arm. Leads to progressive muscle weakness and loss of fine motor coordination of multiple limbs over time, and eventually leads to respiratory failure and death. Manifestations are related to both the upper motor neuron and lower motor neuron dysfunction. Upper motor neuron damage to axons in the lateral spinal cord results in spastic paralysis and hyperreflexia. Lower motor neuron damage leads to flaccid paralysis and decreased muscle tone. The loss of these neurons occurs in a diffuse and asymmetrical pattern that proceeds without remission. It is a progressive course with a mean survival period of about 2 to 5 years. However, a notable exception is Stephen Hawkins. There is no cure, but treatment is with anti-glutamate drugs. Multiple sclerosis is an autoimmune demyelinating disorder characterized by inflammation and destruction of CNS myelin. The etiology is unknown but involves both genetic and environmental factors. Women have about a 2 times greater likelihood of getting it than men. The risk increases about 15 times if you have a first-degree relative with MS. People with human leukocyte antigen haplotype are more likely to get this. And also, there's a link between the resident living in northern climate and low vitamin D levels and the incidence of multiple sclerosis. The onset usually occurs between the ages of 18 and 45. It results in demyelination of these neurons, inflammation, and sclerosis or scarring of nerve fibers in the central nervous system, the white matter of both the brain and the spinal cord, and the optic nerve, leading to this causes slowed nerve conduction velocity, which results in its effects. In the case of multiple sclerosis, we have sensory, motor, and autonomic nerves are all affected within the central nervous system. The earliest lesions are a result of inflammatory response, and we begin with loss of myelin in the white matter of the brain, spinal cord, and the optic nerve. So these arrows point to areas where myelin is lost, where it doesn't, and you can see this as it doesn't appear white. Plaques are larger areas of demyelinated or sclerotic patches, and these are visible macroscopically throughout the white matter of the CNS. That's what I just showed you. Multiple sclerosis is also characterized by remissions and exacerbations. So the initial inflammation may subside, and then neural function may return to normal for a short period of time. But over time, neurodegeneration becomes irreversible. Manifestations depend on the areas that are demyelinated. For instance, if the cranial nerves are affected, that results in visual problems, speech, and articulation problems, depending on which nerves are affected. The cerebellum will result in gait, coordination, and balance problems. Corticospinal tracts will result in muscle weakness and paralysis, spastic paralysis. Sensory nerve tracts is going to result in paresthesias, and burning sensations. Some common early signs are fatigue, blurred vision, and the paresthesias. Progression over time results in progressive weakness and paralysis, extending to the upper limbs, loss of coordination, chronic fatigue, bladder, bowel, and sexual dysfunction, and complications related to immobility. There is no cure, but treatment is aimed at treating the acute attack with steroids, modifying the course of disease with interferon, and treating symptoms. Huntington's disease. This is an inherited disease characterized by chronic and progressive chorea, as well as psychological changes and dementia due to brain atrophy and neuronal death. It is autosomal dominant, meaning if you have one parent with a mutated gene, you have a 1 in 2 chance of getting this disorder yourself. It usually does not manifest, though, until about people are in their 40s or 50s, so they could unknowingly pass this gene on. About 10% of Huntington's patients, though, have juvenile onset. Huntington's disease leads to progressive atrophy of the brain and degeneration and death of neurons. It especially affects the basal nuclei and the frontal cortex. We have depletion of the neurotransmitter GABA in the basal nuclei, and we see low levels of acetylcholine in the brain as well. This also results in ventricular dilation due to that atrophy of the brain tissue. Manifestations: chronic progressive chorea. Okay, it's not in English, but you can, try that again. Okay, they also have bradykinesia and rigidity due to damage to the basal nuclei, impairment of voluntary and involuntary movement, dysphagia or difficulty swallowing, depression and personality changes due to atrophy of the frontal cortex, and dementia also due to atrophy of the frontal cortex. There is no cure, and currently there's no therapy to slow or progress this disease. Symptomatic treatment is given for some of the motor and behavioral disturbances. Alzheimer's disease is the most common form of dementia and the 6th leading cause of death. It negatively affects memory and thinking, behavior, and personality. It starts with an onset of memory loss followed by dementia that in most cases progresses over many years. The etiology is unknown, but it's thought to be a combination of genetic and environmental factors. Age is also a very important factor, as the risk of developing Alzheimer's dramatically increases with age. There is no definitive diagnostic tests available until autopsy. Rather, diagnosis is made by excluding other possible causes of dementia. Alzheimer's disease is initiated by accumulation of amyloid beta in the brain. We have neuritic plaques, and these are clusters of degenerating nerve terminals that are arranged around a central amyloid core. We also have neurofibrillary tangles, and these are fibrous proteins that are wound around each other in the cytoplasm of the neurons. We also see decreased acetylcholine production within the brain, and we get atrophy of the frontal and temporal lobes, and that's going to result in that dementia. Plaques and tangles are found throughout the cortex, as well as in the hippocampus and amygdala, but the primary sensory cortex is mostly spared. Signs and symptoms. We have a gradual loss of memory and a lack of concentration, impaired learning, poor judgment, behavioral changes, mood swings, a decline in cognitive function and memory and language, change in food take, and neglect of hygiene. They can become unable to recognize family. They have a lack of awareness of their environment, incontinence, and inability to function. There is no cure. Drugs are used to slow progression, control agitation and depression, and sleep disorders.